Today we're here to perform a exam on listening for the lungs and the thoracic area of the posterior and anterior portion of the chest. We would gather our materials first with a stethoscope, a pen, and a ruler to be able to mark off some areas. Previously we had done a health history on this patient, and he denies any problems with breathing, any infections, denies smoking, no respiratory problems, no labored breathing, no coughing or spitting up vomiting or spitting up blood or anything like that. Everything is actually a clear history and what he had said that prior to this examination. Moving on with this examination, we would first assess the patient's respirations by looking for two characteristics. We're going to be looking at the rate at which he is breathing, which should be between 12 and 20 breaths per minute. We are also looking at the rhythm, making sure that he is breathing easily and regularly without distress, not using any accessory muscles, and that the chest is expanding bilaterally and symmetrical. Some terms for abnormal respirations would be tachypnea, which is a rate greater than 25 breaths per minute, bradypnea, which is slower than 12 breaths per minute, hyperpnea, which is deep breathing. Kussmaul's respirations and breathing is deep, usually rapid breathing associated with metabolic acidosis. Hypoapnea, which is abnormal shallow breathing, and Cheyne-Stokes, which is irregular breathing with intervals of apnea. Again, moving on, we're going to now look and make sure that everything is symmetrical in the chest expansion, and we're going to ask the patient to turn around, okay, as we are looking at the posterior portion of the chest wall, looking at symmetrical, making sure that there is no lordosis, scoliosis, or cridosis. The patient looks like everything is symmetrical here. We're going to palpate down and look and make sure that there's no lesions or bumps. Looking at the skin, making sure that the skin is good in color, that there's no pallor. Turning the patient back around, we are going to look at his lips and nasal flaring, making sure the lips are not blue in color or the nail beds or clubbing of the nails, indicating problems in breathing and possible cardiac. Asking the patient to move back around, we are now going to start to move on and start doing some of the examination here. Again, we've already palpated and looking down, making sure everything is symmetrical. We're now going to do what is called the tactile fremitus, asking the patient to say 99 while we percuss. As I go down your back, could you please say the word 99?
99, 99, 99, 99, 99, 99, 99.
Okay. Could you please say 99 again?
99.
Okay. And everything is good. Moving on for chest excursion, we're going to be percussing down the patient's back and marking off where we had here renaissance. Okay. Okay. We've already marked these off earlier when we had done this, taking our, which should be a small little ruler, but we have a big one, taking it and measuring in centimeters, should be 3 to 6 centimeters. And that is what we have with this patient, so everything is good with that. Okay. I'm now going to actually listen to the back of our patient and listen for the lung sounds. Please. Very good, nice and clear. I'm going to ask the patient to raise his hand above his head. Very good. If we could do that with the opposite side. Very good. If we could turn back around. Okay. We're going to palpate the chest walls. Okay. Percussion, listening for renaissance and dullness. Inspect the trachea. We're now going to listen to our vesicular and bronchovesicular sounds. Everything sounds clear on this patient. Everything is symmetrical. There's no abnormalities. And this concludes this assessment for today.